afternoon, everybody. It's 4 o'clock on the East Coast. I wouldn't normally say of the United States, but I'm in Canada right now. So we are live with the webinar, but everybody else is going to see this hopefully by tomorrow. And you'll catch it on YouTube and Facebook and all of our other platforms. So a couple of months back, maybe 10 months ago now, Jen and I met first on a podcast to discuss some healthcare access issues. And today we are going to continue that conversation as we enter the really tricky time of year for health insurance, and that is open enrollment time. And I say this with all candor and understanding that we are living in a very unusual time when it comes to healthcare access. We know that there are some very big problems in the United States with how we are going to access care, and things aren't clear right now. And we know that causes a lot of stress. So we're going to try to take away some of the uncertainty and some of the stress by providing you with a little bit of information today about some issues related to access. Jan and I could probably start talking today and end in like 3 months if we want to talk about all the access problems. So without further ado, allow me to introduce Dr. Jan Berger, who is also a member of our board of directors as of this summer. So a face you'll see a lot more of, I hope. And Jan, why don't you tell them a little bit about your background from your perspective, and then we can jump into some of the slides we have for today.
Sure. Thanks, Lisa. So I'm Jan Berger. Interestingly, I am a physician. I have a medical degree, a law degree, neither of which I use formally anymore. I've spent a large portion of my career as a healthcare executive in a number of ways. And 2 years ago, September, I was diagnosed with HCM at age 66. Previously thought I was very healthy, did not know I had family history. It has led me to, besides learning more than I ever knew because I had never heard of HCM, but it has become, as Lisa will tell you, a cause célèbre for me in a number of ways and a passion. And not only did I get Lisa as a mentor, I got Lisa and the team at HCMA as friends. So what I'm hoping today to do with Lisa is, because I spend a lot of time in my career part of my life, running a healthcare consulting company, previously a leader at a PBM and a leader at a health plan, helping all of us as a whole to understand the challenges of access for those of us who have family members or ourselves who have HCM. So that's why we're here today. The one other thing I do want to say, when we talk about access, that can be many things. Lisa and I are going to talk about access both through insurance, being able to see a doctor or a healthcare professional, because even if you have insurance and you can afford it, the challenge of seeing somebody today is big. And then the out-of-pocket costs. So we're going to talk about the big access issues and try to bring it down to just a few suggestions as we look at the challenges around access. Lisa, does that make sense to you? Lisa, you're on mute.
And I'm working off of a Surface now, not a laptop, so buttons aren't where they used to be. Sorry about that. Yes, Jan, that's exactly what we're going to talk about today. Great. And we are going to take your questions. Oh, we already have a question. Let's see what the question is. Yes, you are muted as participants. You are able to use the Q&A feature. As we run webinars, it's just too chaotic for people to start talking. So you will use the Q&A feature. We will address each question as we can. If you've asked a question that we cannot provide an answer for, we're going to say we don't have an answer for you. We will be talking about Medicare. Okay, so I answered that one live, Christine, and Drew, I answered yours. So you can't disrupt us. You can just ask us questions in the Q&A box, and we will do our very best to get to it. and you will see my glasses go off and on, and you will see me do things like this because I can't read. Okay. So Julie, do you want to do a screen share? Julie's behind the scenes here managing our slides. So we could put that in. Ah, and we're already in present mode. Julie, you're a pro. Thank you.
There you go.
Okay, so next slide, please. Jan, the floor is yours.
So, the reality is HCM requires attention by us, by our families, and our healthcare team. There's lots of decisions to be made, but at the end of the day, we have to be our own advocates. This is on our shoulders. We have to make decisions. And I'm going to give you a couple of examples, and I'm going to start with myself. And that is, I just had to change my Medicare Part D. That's the Medicare medication part of Medicare. And I had to do all the research to figure out, with the drugs I'm on, which is going to be the best to cover me, because my benefits last year no longer available to me. So what is my out of pocket? What are the barriers through prior authorization or medical exception? I had to be my own advocate. I will also give, for those of you who are commercial, so you're getting your insurance through your employer, a couple of examples. Often when we think about our benefits during open enrollment season, and Lisa, you lived it sitting on the other side
I did.
as the benefits executive, it's not just your medical and your pharmacy. It is also the other benefits, whether there's gym membership or a population health or disease management company. Really understanding your benefits. Is it boring? I compare it in some ways to having to get a new roof in your house. Not a sexy place to spend your money, but really important, especially when it rains. And I think of our healthcare, and when we're having our medical needs in HCM, is that rainy day. So not sexy, but you need to educate yourself. So please be your own advocate. If you don't understand things, don't be embarrassed. Ask family members to look at it. Go to others who may understand and ask the questions. So that's really where I'm going to start and end our conversation today, that there's a lot of responsibility on us. We can't control everything, but we can make decisions that work best for us.
I'll just add to that before we get on to the next slide. The the terminology has changed a great deal over the past 20 years. Concepts and policy types and plan designs that didn't exist in the past have evolved. So if you hear terminology that you don't know what it means, if you have an agent, ask your agent. If you have an HR representative, ask your HR representative. If you need to call a Medicare helpline to better understand, there are services out there that can help you make sure you understand all of the words and what they actually mean. And I know that sounds simplistic, but there's a lot of new terminology. The one that I still laugh at is alternative funding mechanisms, which is actually a part of a healthcare plan now, an alternative funding mechanism. What the hell does that mean? We'll talk about that a little bit later, but there are terms that you might say, I've never heard that before. Is that new? It's okay. Write it down, take the notes, ask us what you need to find. If you go back to our last session, we talk a lot about terminology. So you can go back and revisit that if you get lost in anything as well. Julie, next slide. And Jan, back to you.
All right, so significant changes are across healthcare. Whether you get your news on social media, a newspaper, old-fashioned TV, anything else, healthcare and health insurance is in the news today. So what are we seeing? There's marketplace instability. What do I mean by marketplace instability? lots of new insurance plans and lots of insurance plans, like I talked about with my Medicare Part D, my Medicare Part Drug, going away. So lots of instability. We could spend hours on why that's happening, but it is the truth of the matter is right now it is happening. Number two, we're seeing premiums, the cost of your monthly health care bill going up. And I don't care if you're commercial, getting it through your employer, if you are Medicare, if you are Medicaid, or you are exchange. All of them are going up, some of them for different reasons and at different levels, but going up anywhere from 5 to 80%. So premiums are going up. There are changes. And when I talk about networks and coverage, what I mean in networks is who are the doctors that your insurance covers? Who are the hospitals your insurance covers? Who are the pharmacy that your insurance covers? Those are changing as well. And as I said before, know what you're buying and know what you can use. Make sure, if at all possible, that your doctors, your hospitals are covered by the insurance that you are choosing or being given. If it is not, then you need to start looking for new doctors or new hospitals. Sometimes that's a big deal, sometimes it isn't a big deal. I would argue, and I'm going to get myself in trouble, but that's not new. Having to switch from a Walgreens to a Walmart or a Walgreens to a CVS is not a big deal. It's a hassle, but it's not, you have to set everything up again. But this is not the end of the world. That's not where you should, unless you are in a town that has just one pharmacy and nothing close by. And by the way, 99% of the country is within 5 miles of a pharmacy, and 80% of the country is within 1 mile. So having to change pharmacies, don't sweat that one, you guys. So why is the what is what's happening? The why, we are getting older as a country. Inflation is out there. Changes in our government with Health and Human Services and CMS and things of that nature, because different leadership has different things that they consider important. I'm not going to go into that any deeper than that. And the truth is, the reality is, it's a good time to have a bad disease, but these things cost money. And the cost of those things goes up. So all of these things, a lot of it is where the focus is or what the costs are causing all the things that you see on the left side. Lisa, what's your thoughts? What's your comment? Come on, this is football season. You are my commentator here.
So I am just managing some questions here that were on the back end that I just needed to clear away. So I'm looking at the computer funny right now. So there's a couple of other things that I would remind you to consider. So changing pharmacies is not terrible, but it is a pain in the ass. It has taken me upwards of 8 hours to change from one plan to another and get all my pharmacy stuff set up. 8 hours for the year, like at the end of the year to set up the new one. So I've been through those struggles. Document, 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 and make sure everything is being transferred over and that you're not leaving anything in the old pharmacy because that can happen. We are in a so for those who don't know, before you had me in this position, I was a health plan administrator for 20 years roughly. And I managed a small healthcare plan for about 103 employees or something at its max, which is like 600 lives. So tiny, tiny micro program, but we did it ourselves. So I was on the employer side and I could argue why this was the more effective way to use my dollars. And on the patient side, I can balance it over there. I actually tried to put the two of them together to create the best scenario. And it actually worked. It was when PBMs were new. And now we're getting legislation moving on PBM reform because they've gone a little crazy. PBM. Jan, you want to tell everybody what a PBM is and why they're good and bad?
Sure. A PBM is a pharmacy benefit manager. So it's basically drug insurance. And they are good because they can oversee and make sure your two drugs or three drugs, or in the case of myself with my HCM, seven drugs, don't have drug to drug interactions. They also are good in that they can sometimes help to reduce your costs. Why are they bad? They are bad because they are not always, their goals and your goals are not always aligned. And again, I could spend a whole hour just talking about PBMs. I won't. I know where the bodies are buried because I was an executive for one for 11 years, a senior executive. But they get, they negotiate with the pharmaceutical companies to create the formularies that we all live under. And they do it by what is the best cost they can get. That does not always align with what is the best medication for you to be on. So to keep it at a high level, they are who makes the formularies, the drug lists that help you to know what you can buy for how much money.
And typically, the generic drugs that many use are easy to get and inexpensive. Where things start to get a little tricky is when you have labeled drugs, new drugs labeled for HCM. And we've had that just since 22 in Camzyos. Aficamten is probably going to get a label by the end of the year. So we'll have another name drug. We're using Farxiga and Jardiance kind of off label right now. So these are drugs that require prior authorizations. They're a little bit more expensive, and insurance companies cut deals through the PBMs to make them available to their communities. However, their their interests and our interests are not aligned 100% on getting us those medications. So you've got to look at your plan design and your formulary to see what drugs are there and then what drugs you might be able to get through an exemption or whatever word they want to put on it. Prior auths are one pathway, getting an exception is another. Jen, you want to talk about what happens when something's not on formulary?
So, if something is not on formulary, and let's use Camzyos. It's a great example. Camzyos for Medicare is only on one formulary this year. It was on none last year, so we're getting better. But what you do is you go through what's called the appeals process. And by going through the appeals process, and the good news for any of you who are getting your care through centers of excellence, and I hope most of you are, um, they are very good at working through the appeals exception process. And if anyone's going to get you that drug covered, even though it is not on a formulary, it will be your COE. That is how the last 2 years I got my Camzyos. Interestingly, this year, instead of having to go through the medical exception, I will be going through prior authorization. And what that means, because as I said, there is one Medicare plan that does cover Camzyos, but it is through prior authorization. They will see that I've been on it for 2 years, that it is FDA approved for HCM, which is why I'm getting it, and that I fit within the guidelines and the REMS model for this. It is not the only drug that you may have to go through a prior authorization or appeals or a step therapy. So, working with your providers and your doctors is really the best way to hopefully get you the drugs you need. But the starting place is if you have a choice for different insurances, look at your drug list, make a list. I am a paper person. Guys, I have paper with me everywhere. I have lists everywhere. And one of the things you do is you write down all of your drugs, you write down all of your doctors, you write down all of the hospitals and the systems you use, and you benchmark that against the choices you have in healthcare.
And when you do that, you have a mild panic attack because nothing is going to line up 100%.
You're
So
right.
something will probably have to get fixed. Okay, I'm going to step on my soapbox for just a hot second. Richard Nixon, go back to him. If you want to say, how did we land where we are? You got to kind of go back to that point in time. And healthcare in the United States has kind of been this devolving juggernaut since then. So every year you're making a choice as to where you're getting your insurance. And for whatever reason in this country, we decided that your employer should be the one making that decision for you. And then we fixed it in 2012 when we brought the ACA in so you could get it outside of that. And now they're threatening to take the subsidies away that they would for make it less affordable. As you document your journey and you look at your list of drugs and you look at your list of doctors and you look at your list of options and you can see how much it's going to cost you before you pay a dime for your pills or your test just in premium, please keep records. Please keep your notes because we're going to have to bring that someplace else at some point to discuss the greater problem of healthcare access in this country. But going through this exercise of documenting and writing and comparing and seeing what you had last year and what you're going to have this year and how much more it's going to cost you and inflation and all of the pieces, we've got to start documenting this as individuals so that we can bring the collective to bring policy change. I will step off my soapbox now and hand it back to Jan.
All right, why don't we go to the next slide? So, we have to focus our attention. We have to be patient. We have to, in many cases, our family members are helping us with this, and our medical teams. And each of them have a role to play in how we look at access. And I'm really not going to go more deeply into this, except to say we really require all of these things to come together. That's the HCM challenge and the HCM opportunity. As Lisa stated, you know, sometimes you can't get it all, right? So you gotta look. I am a believer that a strong medical team that understands HCM. So if you aren't lucky enough to be somewhere where you have a center of excellence, potentially going somewhere else once a year or once every 2 years and using the center of excellence as your expert and then your local cardiologist as your day-to-day may be the way you have to do it. But having your medical team as the center of your medical world along with yourself is really the most important because HCM is a disease that many people don't know about. As I said, I'm a physician. I had never heard of HCM. I'm very lucky. My internal medicine doc is who diagnosed my HCM 2 years ago. She's not a cardiologist. And I said to her, how did you even know about this? And she said she had a patient who she didn't diagnose several years ago, but she was their, their quarterback as their primary care doc. And so she had done her research about HCM. Not everybody knows about HCM. Make sure you have somebody in your insurance access world who knows this disease so they can help you by being your quarterback here.
If you're not sure, we have a question here from somebody who's just diagnosed in the past year. go to our Center of Excellence list. Maybe Julie can do us a favor and drop that link into chat where our Center of Excellence listing can be found. And you can look for the doctors that are at those centers, see what's closest to you. And if you don't have a center yet, make sure that a center is in your care plan options for whatever plan you're picking up. So, okay, so I answered that question. We do have two questions here, which we're going to get to. And the big question is, which Medicare Part D covers Camzyos? And which supplements should I get for Medicare? And what else can I insure myself with? So we're going to be answering those questions coming up. Jan, back to you.
All right, next slide. All right, so insurance types. Here's insurance 101 for 1 second. Commercial means employers, okay? And as Lisa said, since actually post World War II is when the commercial insurance market came about. I'm not going to go through why. There is a reason for it. We are the only country where commercial is the primary model. There are many other countries where employers do help in insurance, but ours is the primary. Number two is Medicare. That is people over the ages of 65, as well as certain other medical conditions. Interestingly, Medicare, when people say, and here's my momentary soapbox, and I'm sure a few people won't like what I have to say here. We all complain, I don't want government insurance. Interestingly, the most popular and happiest patients are people who are on Medicare. All right, over 90% of people on Medicare love Medicare. It is a government program, guys. So you've got Medicare, which is 65 and some other conditions. You have Medicaid, which is means tested. So again, it is generally a socioeconomically driven government program that is a mixture of state and federal. And then you have the exchange, which really came from the Affordable Care Act, also known as Obamacare, but it is the Affordable Care Act. And it was the first time that we were able to insure between 20 and 40 million people who had never had insurance. So, you know something, having insurance is a really good thing. I don't care who we like as presidents and who we don't. Having people insured and being able to get health care is a really good thing. So those are the four major insurance types out there today. And we're going to spend a minute on each of them. Lisa, anything before we go and do a deeper dive in the four?
So remember, when you're looking at commercial insurance, there's many different plan designs.
Right.
HMOs and PPOs and EPOs and indemnity plans. So look at the details, because for those of us of a certain age, we remember very restrictive HMO plans. Then HMOs got a bad name, so they changed the name of HMO so you didn't know it was an HMO and that you were stuck in a very small network. So again, those words make a difference here. So look at whether you need a referral to go to a specialist or you have a gatekeeper doc that's going to make those referrals. And if so, if it's a closed system, you can't really make a lot of choices out of Kaiser. If you buy Kaiser, you're in the Kaiser system. And you can buy plans that are Kaiser systems through your employer. So you got to look at your details as to your how you're getting it, where you're getting it, and all of the designs that exist. And then again, the ones that they'll pop up with that we never heard of before. And then we have to figure out the definition along with you. I will leave it there. Jan, back to you.
All right, next slide. We're going to spend a minute on the employer-based commercial insurance. Mostly we're going to see increases of 10 to 15%. I just actually was looking at today. Some people are saying that the premiums are about 7% increased. Small businesses may increase even more. Over the last few years, how much we pay out of pocket as the employee had moderated and we had saw it not going up as fast, we may see it go up again this year. We're also going to see what's called narrow and high performance networks. When we talk about networks, again, as I stated earlier, those are the doctors, the other types of providers, and the hospitals that are covered by our insurance. That is the network of healthcare that my insurance is covering. What we're starting to see is them shrink. And they're shrinking through contractual arrangements. In some cases, it's the doctors and the hospitals who are saying, I'm not going to be part of this insurance. And in some cases, it is the insurance company saying, I don't want these doctors, healthcare providers, or hospitals involved. So it's both sides. The good news is there is a greater focus on wellness and mental health. And we talk a minute about mental health because I would argue none of us with HCM go through our HCM lives without having days of frustration or anger or depression. It's why HCMA is now doing the Hearts and Minds project, because I am a huge believer. All of us have days of depression. All of us have days of anger. Many of those days I am texting or emailing or calling Lisa and saying, help dig me out of this emotional hole I'm in. Our insurance now is putting a greater focus and covering wellness and mental health to a much greater degree. That's the good news, especially around employer insurance. Lisa, anything you want to add there?
We're going to have sticker shock this year, and everybody's going to be afraid they can't afford their insurance premiums. And I'm here for a reality moment. If you find yourself in need of a defibrillator, a device replacement, surgery, an expensive new precision medicine, you need insurance. You need to reallocate your budget to afford it, because we're not going to be able to help you get charity care all the time. There's going to be some charity care available, and it's going to go fast. So make sure you have some basic coverage. If your out of pockets are higher, then you can talk to the hospital system about charity care for your deductibles, but they're going to want some coverage. God forbid you end up on a transplant list. You want coverage. You need coverage. And if you can't truly afford coverage, you really should be talking to your elected officials on the federal level about what they can do to help you, because we're not going to have the resources to help everybody get there. So that's dismal. That's depressing. I don't like to say we're not going to be able to help, but we can't pay $300,000 per person or have a hospital cover $500,000 here, $500,000 there. We've got to have some coverage. And we have to have reasonable charges, but we need coverage. So I will leave it there that it's not going to be easy. And if we want to make it better, get involved and share your voice. But right now, this is our reality. Jan, back to you for some more uplifting news.
Well, yeah, I mean, Lisa and I are going to do a pharmacy educational program, because there are some things, and Lisa talked about talking to the hospital. Interestingly, if you go to a hospital and you say, I'm having to pay for this out of pocket, they will discount your bill. In the pharmacy world, there are many things that you may hear about, GoodRx or Mark Cuban, and we're going to do a deep dive one day on this, because there are ways, sometimes cheaper than your pharmacy insurance, to get your drugs. So we will go and do a deeper dive somewhere. But let's go on to the next slide. And this is just a quickie here, guys. Interestingly, I don't know why our the red thing got moved to diabetes. It should be at
It
cardiovascular.
should be, yeah, it got moved.
So we'll have to fix that for next time. But I wanted you to see that heart disease is the number 3 thing driving. Our condition is one of the things that is driving healthcare costs. So this is something that should matter to all of us. And that's just where I wanted to spend our time so you can see what diseases are causing all this. Um, Cardiovascular is right up there and it continues to go up in costs. Interestingly, 2024 cardiovascular, you saw a bump. Some of that was things like Camzyos and other medications that are out there. So keep an eye on that. Needless to say, this next year, and many of us who have heart disease also have diabetes, also have mental health, also have obesity. So it all comes together. Next slide. Alternative plans. Lisa, you talked a minute ago or a few minutes ago about alternative health insurance. And there are different plans out there. I want all of us to be very, very careful because some of these lower cost plans cover very, very little. So you think you're getting insurance and it's going to cover for your healthcare needs, and you find out it really isn't. So back to almost the very beginning when Lisa and I talked early on in this hour is know what is being covered. So when you look at what's called low actuarial value plans or catastrophic plans only, these things cover very little. Only when you have $100,000 worth of hospital bills, in some cases, does it cover anything. So please be careful. Lower cost often equates to lower coverage. I hate to say it, but it is the reality. Lisa, before we move on, is there anything specific more that you want to talk about?
Warnings, 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 warnings. I think the mini med plans are going to try to come back in.
They are.
I have heard some news clips this morning about, oh, well, let's go bring back those high risk pools. Good God, no, no high risk pools. High risk pools disenfranchise us from access because they price them so high. So there's going to be some gameplay coming up. And if you're on this webinar, you are a smart person because you're getting information. So I know something about you. But if we start hearing scams and schemes coming up as long-term solutions, call them out on it. Call your elected officials and say no gameplay. We just need access to healthcare. Out of 34 industrialized nations, we are the only one who cannot figure out how to do a public and a private option. We're the only ones. The other countries, guys, I've been there. It's going okay. It's not perfect anywhere, but we can do better. Don't let them gameplay you. I stepped down off my soapbox yet again. Back to
All
you.
right. Next slide. Let's talk about Medicare. As I said, I am a fan of Medicare. I am also covered by Medicare for the last 3 years now. There's good and there's bad to Medicare insurance plans. We are now in a world where Medicare must submit, the Medicare insurances must submit provider directories. And what they're starting to do is to check to see if the doctors really are in the directories and if the doctors exist. For a while, there was an issue of what's called ghost directories, where the doctor's dead, but they're still in the directory, or the doctor doesn't exist, or the doctor isn't covered by that insurance. This is now a mandate, and they're taking it very seriously. It's a good thing that the government is doing. I don't often say that. Changes are coming to the prior authorization and appeals process. So we're going to have our day to be able to speak up. There are certain insurance companies that are getting a lot of bad press because their prior authorization denial rates are so much higher than everybody else's. And so that's being watched. The Medicare Part D payment plan. A year ago, or 2 years ago now, actually, Medicare Part D, so the Medicare drug part, started to say instead of this month, because you're getting this very expensive medicine, maybe for 90 days, your bill is $400, and next month it's only $100, they created a leveling capability so you had a payment plan. And it was easier to pay a regular payment once a month instead of these highs and lows. And it made it easier for people to pay. That's going to get even easier to use. That actually came in the Inflation Reduction Act 2 years ago. And it's really a good thing for people who are on Medicare who may be having some trouble paying their monthly bills on that. More medications are going to be part of the Inflation Reduction Act. That's where the government now can negotiate lower prices for medications. And that has brought down. Lisa talked about Giardians and some of the other drugs. Those prices went down pretty significantly last year because of the Inflation Reduction Act drug negotiation program. The one other thing that I don't have here is also part of the Inflation Reduction Act was the maximum out of pocket for those of us on Medicare last year was $2,000. It is going up this year, but it's only going up by $100. So when I pay for my Camzyos in January, guess what? I will pay, instead of $8,000, I will pay $2,100. That will be for the first month, and then all 8 of my drugs for the year, including Camzyos, will cost me nothing. These are really good things that came out of the Inflation Reduction Act. It really helped people like us around that. Now, let's talk about the bad things. There will be fewer Medicare plans and options in 2026. We went live with Medicare, the over 65 insurance, went live for our open enrollment a couple weeks ago. I have spent so much time with friends and my mother's friends helping them choose plans. It could be a full-time job for me, as well as figuring out mine and my spouse's. There will be less to choose from. Often, those of us in Medicare, if our plan worked well for us, the next year we don't change anything. But if the plan doesn't exist anymore, like what happened for me, I have to start over. We talked about the networks narrowing. That means there will be less choices of doctors and hospitals and other providers. So you have to look at that. We've talked about out of pocket being more. So people who have Medicare and Medicaid both, they're called dual eligibles. And they will see a number of changes. I'm not going to go into depth with that today, but they too will see changes. This administration had promised that there would not be major Medicare cuts. But because of the increased deficit going on and other things, if you are a Medicare member, so if you are over 65, I highly suggest that you join for $12 a year. It is not as expensive, AARP, because they are fighting to keep our Medicare intact. And so we over 65 are a big voice, but we all have to use all our voices. Otherwise, we're going to see cuts at a time where cuts were promised not to occur. Lisa, anything around the good news, bad news, Medicare area?
I think you laid it out nicely. I think there's some tricks to the smoothing aspect that people should be aware of for those who can't afford to pay $2,100 in a monthly bolus. There is an opportunity to, and I don't know that this has actually been perfected yet. I've heard of a couple of different ways that it's worked, but you have to notify your pharmacist before they process the prescription that you're looking to do the smoothing. And you may have to sign up online to do that, and the pharmacist can guide you how to do the smoothing. So make sure that you know what you're getting into. If you can afford the $2,100 in January for that first copay, do it, and then you don't have to do paperwork all year. But if you need to stretch it out, make sure you know how to do that. Don't miss that opportunity.
Right, because
Um,
it's great. It's really it's a good thing, but get the help
it,
to do it. You're right.
I would say next to ACA passage, I think the benefits that the number of Americans got from the Inflation Reduction Act related to access, as we're talking about here, that might have been the biggest move forward that we've had in public health access in the last 15 years. And I hope it doesn't go away.
Me too. Me too.
Back to you.
Okay. Next slide. Before we leave Medicare, I want to spend a minute, and I know we're often asked, Medicare Advantage or Medicare Supplement? I will tell you I have a bias, and I will explain my bias. If you can afford Medicare Supplement, get Medicare Supplement. It may not cover the extra money that you spend on over-the-counter medications. It may not get you a dentist. It may not get you eye exams, but it will allow you to see any doctor in the United States and any hospital in the United States that takes Medicare. Medicare Advantage does not do that. So, for example, Mayo has come out and said they will not be taking Medicare Advantage. So, anybody who is getting their health care with a Mayo Clinic doctor or the hospital, the clinic, and is on Medicare Advantage, you are going to have to either get a new provider or you're going to have to get new insurance. The other issue is if you start in Medicare Advantage and then you decide you want to go to Medicare Supplement, it is almost impossible. And in fact, if you can even do it, it is so crazy expensive. So your flexibility of choosing to move to supplement goes away if you start with Medicare Advantage. That means even if you are super healthy, if I had at 65 gone with Medicare Advantage because it is so much cheaper and I was way healthy, I was on zero medicines and I had zero medical problems, and a year later I found out I had hypertrophic cardiomyopathy, I would never have been able to go to Medicare Supplement. So if you can afford it, please, please, please choose Medicare Supplement. Your prior authorizations are not as difficult. You can choose more doctors. It just gives you the flexibility you need. Also know that you may say, oh, but my doctor is covered by Medicare Advantage. Next year, when they negotiate with the insurance company, they may break up. There may not be a contract between your insurer and Medicare Advantage and your doctor. So I do have a bias because I want control over who I see and what specialists and what care. That does not happen in Medicare Advantage. Lisa?
Well, I gotta tell them all a secret. I haven't done anything with it yet, but I might have bought a URL, and I might buy a lot of URLs, but I might be the proud owner of MedicareDisadvantage.com, which we have not populated yet, which gives you an understanding of what I have dealt with Medicaid or Medicare Advantage programs and their lack of transparency about what medical care is actually covered and what fluffy benefits, I'll call them. And, they might give you some money for food every month, or they might give you money for a gym membership or transportation to the doctor when you really need the diagnostic test and the medicine from your health insurance company. So please be very, very careful. And now I think we're going to hit the item that some people have been waiting for on where can they get the best Medicare supplements. Jan, back to you.
You know something? Interestingly, Medicare supplement, if you go to a G plan, so there's a bunch of different letters, and if you go to a G plan, whether that is United, whether that's Blue Cross Blue Shield, whether that's Aetna, whether it's Humana, they all give you the same thing. So what you have to be looking at, interestingly, is what plans are offered in your zip code, in your county, and which of them, what number or what letter plan it is. The higher up you go, and G is the highest, gives you the most flexibility and most coverage. Because many of us have, if it's not you, it's your family member, have hypertrophic cardiomyopathy, you're going to need, you're going to need more coverage. And so whether it's the F or the G plan, that's what you're going to be looking at. So in Medicare supplement, there is more equality than there is in Medicare Advantage. By the way, you said something, Lisa, quickly, and I know we're getting to the end of our time, about gym membership. Most Medicare plans, including supplement, do have a gym plan. So for example, I have Blue Cross Blue Shield Medicare supplement. I have Silver Sneakers. There are several gyms within 10 miles of my house that, just as long as I go several times a month and meet the requirements, I pay nothing for my gym. All right? On the other hand, Medicare Advantage, which we're buying people historically by the, as you called them, fluffy benefits, a lot of those fluffy benefits are going away. So it's a different thing.
We have a question from Debbie.
Yeah.
How are insurances allowed to change their plans and providers mid-year on Medicare Advantage and not allowed in traditional states?
They are not supposed to be changing. They can change their drugs mid-year. They are not, unless there was a contract that was a mid-year contract for a doctor, they generally cannot change their plan design. They can change, they cannot change their plan design, but a provider may say, guess what? I'm out of contract now. I'm not going to negotiate. So that's how they do it. Is it's a disagreement between the provider and the insurance company.
So going back to Christine's question from earlier,
Mhm.
which Medicare Part D covers Camzyos? Is that an answerable question at this time?
Yes, it is, because it's public knowledge. HealthSpring, it is a prior authorization. HealthSpring was a Cigna. In certain states, it is still Cigna. In other states, it's actually owned and run by Blue Cross Blue Shield right now. But HealthSpring does cover Camzyos, but it is a prior authorization.
Okay, so there was the trick answer that I teased earlier today.
Yeah.
Okay, okay. Jan, back to you. And if
Yes.
I've cleared all the questions that are in the queue right now, so if you have any other questions, now would be the time to post.
Let's go to Medicaid and the Medicaid insurance plans. Medicaid's a tough place right now, guys. There are new rules around Medicaid. There are stringent work requirements that are being put in place as of January of this year. There will be significantly increased enrollment and eligibility verification. There will be tighter federal funding, and significantly tighter restrictions on immigrant funding. Medicaid changes are going to cause significant confusion and access challenges for anybody in Medicaid. Especially is the case in rural and underserved communities. My suggestion to you all is get help. Don't try to negotiate and figure out this alone. Get that, we talked about getting help to start. This is even more confusing and more difficult than it was before. It does mean you're going to need more paperwork. Find somebody to help you with the paperwork if you're having confusion and trouble. Don't be embarrassed to ask, but get the help you need in Medicaid to help figure this all out.
Jan, we have another question. I don't want to get too far from the original point before we answer it. Amy is asking, besides Health Springs insurance for 2026, are there any other insurance that will cover Camzyos or some type of an appeal or
Yeah.
requisition? So
Yes.
can you explain the
Yes.
process?
So here's what you're going to do, guys. The day you know who your insurer is for 2026, you are going to start with, you're going to go to your doctor, especially if it's a COE, and you're going to say, this is my insurer for 2026. I need you to help me start the appeals process. All right. So I'm waiting any day now. I should get my HealthSpring member number, and I will go to Northwestern, which is my COE. I will give it to them because I'm changing systems, and they will start the prior auth process. For everybody else, it's going through medical exception. I've gone through medical, most of us have gone through medical exception. If you are on Medicare and you were on Camzyos, you've been going through medical exception. Just as long as, sometimes it takes time. It could take a couple months, but I haven't seen a ton. There's places here and there, but mostly those of us who fit the profile that's talked about in the FDA are getting Camzyos through medical exception.
And that sounds scary. So in 2022, when Camzyos was approved, I didn't think about a problem that was going to happen later. It didn't happen in 22. It happened a little bit in 23 and it happened a lot in 24. When people moved plans or the Medicaid plans pulled off formulary Camzyos and made everybody go through this exception program. It doesn't mean you're not going to get it. It just means there's going to be paperwork and nonsense. So stay calm.
Right.
If you find yourself running out of medications, then you call the office and then we can try to back channel and try to hurry things along. But the process is going to have to work through the process. So be vigilant, do your due diligence and go and let your plan, your care team know what your plan is going to be as soon as you know it. Amy asked a follow-up question. Can you appeal in 25 for 26? They probably won't accept the appeal until your account is active and you are an
Nope,
insured life.
not necessarily.
Okay.
Interestingly, what's starting to happen is they
Okay.
will start to go through the appeals process prior, just as long as you have your information for January of 2026.
Okay.
All right. The other issue is for those of you who are on Camzyos today, we were having this conversation earlier before we started. But any drug, refill your drugs as soon as you can before the end of the year, guys. It gives you a little safety net. Um, so, don't wait. If your drugs can be refilled on the 26th of December, go refill them on the 26th of December. You don't have to wait till January 1st because you can be on your own old insurance.
I recommend you do that every single year. I do it every single year. I figure out how late I can renew, and then I get my little extra supply of meds for those emergencies that happen throughout the year. Or the time that I need to pack up 8 weeks of medications at a time and not 6 weeks of medications at a time. So just make sure that you are keeping yourself ahead of the curve.
Yeah.
Jan, next slide. Or
All
Julia.
right, let's go to the marketplace. Again, significant cost increases. Illinois, the ACA marketplace is going up 78%. Right now, we have an expiration of the federal subsidies. If the subsidies don't get repurposed, put back into place, it's going to be tough for people. There are less plans that are in the marketplace. There are certain insurance companies that in 26 or in 27 will no longer have a marketplace plan. So no, like Medicaid, there are going to be challenges, guys. Again, as much healthcare as you can get, seeing a doctor, getting your medications, doing what you need to do, any tests you need to have before the end of the year will help you to mitigate some of the costs. On the other hand, getting help for marketplace options, whether you are a subsidized person or not, will be very, very important.
The other thing I want to bring up here, and it's a little left field, but stick with me on this one. I know some of this is not going to be affordable, and maybe the level of program you needed or want isn't available, but get something.
Yeah.
Patient assistance programs are only available to insured individuals. So you have to have some coverage to be covered by a lot of those. You see the TV commercials. If you're having a hard time paying for your meds, or payment assistance programs might be available. Now, there's some stupid people out there trying to actually take that money back and give it to the insurance company because it didn't come out of your pocket, so they don't want it to count as your deductible, but that's an entirely different story. If you don't have coverage, you may not be qualified for assistance. And there might be another path open for you, but there might not be another path open for you. So get some level of coverage. Get what you can. And if you're as frustrated as I suspect that you are at this point, get what you can and help fight for it to be better. Those are the two asks. Jan, back to you.
Yeah, let's go to time to take action. Let's go to the next slide. Here we go. Here's our key takeaways. Don't re-enroll blindly. If you had a good year and it's available again, then that's great. Enroll, but always do your homework. Prepare to pay more. You must actively re-enroll for an ACA plan. You can't just let it roll over. Open enrollment for employers is different from Medicare, is different from ACA. Know your dates. Also know the dates that is the last day you can enroll. Don't wait till the last day, because if you have problems, if a system goes down and breaks down, if we have another day where AWS goes down and nothing's working. So don't wait for all of you guys who did your homework at the last moment, this is not one of the places to do your homework at the last moment. Watch Congress carefully. I don't care if you're on the left, the right, who you voted for, but we have to have a voice in health insurance. And it's very interesting because that right now is the reason that the government is shut down, is over health insurance. I don't care if you're left or right. The issue is right now, Our government is shut down because of health insurance. Health insurance is really important. And for those of us who have HCM, it is even more important. So I don't care who you vote for. Go out and vote, guys. I really, I mean, I may have my preference, Lisa may have her preference, any of you have your preferences. Just go out and vote because that's the only way we're going to get health insurance fixed. So please, do your homework today,
Yeah.
but think about tomorrow and educate yourself and take it upon yourself. As I started out by saying, at the end of the day, there's only one person who really cares about your health, and that's you. So do your work, do your homework, ask for help. Nobody's going to make fun of you for asking for help. And guys, stay healthy, be happy.
Dan, thank you so much. Julie, want to unshare the screen so we can get a little bit bigger here? Okay. So, Jan, we've got a complex landscape to navigate over the next couple of months. And people are going to get nervous. We're going to get stressed. But through it all, we just have to keep focusing on getting ourselves what we need today and figuring out what we can do to make it a little easier for tomorrow. Because every end of year, we shouldn't have to go through this. What's next? What's next? We should be able to rely on our healthcare system. We shouldn't be put into this kind of turmoil that is now literally shut down our government.
Yeah.
Just this conversation we're having with these few people in a webinar today is the entire reason the country is shut.
Yep.
Amazing, isn't it?
Yeah.
I'm so frustrated with that. We should be able to do better. But until we can, take care of yourselves. Remember to keep your appointments. Remember to take your meds as they've been prescribed. If you find yourself at the end of the year and you have not figured out how to insure yourself, please reach out to the HCMA. I don't have an answer for you now, but for those situations where there is no other option, we are going to have to come up with a way to organize those individuals so that we can provide some type of resource and hopefully create a pathway. I don't have that yet. I'm not saying that we will, but we're going to try. But please try to get insured. Please try to talk to your friends and neighbors and family members about this too. It's really important. Keep as many people as you know insured. Help them figure it out. Share this with them when it becomes shareable. And hopefully we'll all kind of muddle through this chaotic chapter together. Jan, thank you for your time today. Participants, thank you for joining us. Julie, thanks for the tech support. And now I'm going to tell you a little secret. I'm going to tell you what I'm going to go do now. You'll see me online, I don't know, somewhere maybe later on tonight. I'm going to get in a car in Toronto and I'm going to drive north somewhere to someplace I've never been before to meet one of the very first people I helped back in the 90s get from Canada to the Mayo Clinic to have a myectomy because they had stopped doing them in Canada. Her name is Connie. She's one of my first and favorite clients. And I haven't seen her since the 90s. And I called her and said, hey, I'm an hour away from you. So I'm going up to her house for dinner. And if she's up for it, I'm going to get her on this little computer thingy and tell her story. And it's a fun day. It's fun for me to be able to do that. So I will be sharing it on social and maybe somewhere else at some point, but that's what I'm going to go do now. So thank you all. Have a great day. Appreciate you all. Oh, wait. We got another question. Oh, okay. We're done. Good. We're done.